Good morning. I'm Alice Newland, President of the League of Women Voters of Manatee County. On behalf of the League, I welcome you. Today's presentation, Social Determinants of Health, is being recorded and will be available on our website. Our speakers will be answering questions at the end of both of the presentations. So please put any questions you have in chat and also indicate whether the question is for a particular speaker. Our moderator today is the League of Women Voters of Manatee County's Healthcare Committee Chair, Ruth Haranchar. Ruth?
Thank you, Alice. And our first speaker this afternoon is going to be Dr. Randall Morgan. By way of introduction, Dr. Morgan is an orthopedic surgeon and administrator. He has been in the front lines of the fight for medical equality for 48 years. Currently, he is a practicing non-surgical orthopedic physician with MCR Health in Bradenton. He has also served since 2005 as the CEO of the W. Montague Cobb National Medical Association Health Institute, an institute committed to finding solutions for racial and ethnic disparities in healthcare. I would also want to add that Dr. Morgan and his lifelong fight for healthcare equity was featured in a Sarasota magazine article in September 2020 as part of the series of Listening to Diverse Voices presented by the Gulf Coast Community Foundation. Dr. Morgan, I turn this over to you and I will share my screen.
Thank you very much. Welcome everyone to what I am sure will be a wonderful discussion, and we look forward to your questions and your comments at the conclusion of my presentation. The title of my discussion today is Health Disparities. And can we start with the present mode, please? Health disparities, health inequity, and the social determinants of health. Because all three
Ruth, can you click on from the beginning?
I think I've gotten ahead. Can you see the opening slide?
Yes,
well, all we can see is the do you want to go out and have me click in, or all we can see is the open?
Just move your cursor over to the thing that says from beginning and click on that on the big ribbon on the top. That should probably take care of the problem.
What are you seeing now? Can you see?
We're not seeing it. Go ahead and go out. I'll bring it up.
Okay.
Okay. There we go.
Okay. All right, thank you very much. So
what
all
slide
right, that slide is fine. That slide is fine. Thank you. I would like to acknowledge and thank the League of Women Voters of Manatee County for the invitation for me to share in this webinar today. I look forward to the comments by my co-discussant, Teresa Kelly, and the Q&A session that will follow. I also thank Ruth Haranchar and Alice Newton for their assistance as we prepared for this webinar today. The topics that we're going to discuss are of utmost importance in our nation today, as we are cautiously recovering from the devastation of COVID-19 and the pandemic, which has beset our community for the past 2 years. The key point is that a better understanding of social determinants of health will help in the rebuilding of our communities after the pandemic. Next slide. I am Randall Morgan Jr., as was previously stated. I was born in Gary, Indiana. I was educated in Indiana. I was educated at Grinnell College in Iowa, where I received a Bachelor of Science in Chemistry. I went to Howard University Medical School, where I received a MD degree, and I completed my orthopedic residency in Chicago, Illinois at Northwestern University. I did not appreciate health disparities or social determinants of health, climate change, and all of the other conditions that we're concerned about today when I was a young person. As it turns out, I lived and worked in an environment that suffered greatly from health disparities in the Midwest and the part of the United States called the Brown Belt. And unfortunately, that situation has only become worse since I moved to Florida in 2005. Next slide. What we plan to do today is to define health disparities, to distinguish the meaning of healthcare disparities and share examples, to define and discuss social determinants of health, to look at the impact of COVID-19 on social determinants of health, and to describe the impact of racism on social determinants of health. In addition to a busy practice as an orthopedic surgeon for 48 years, I've been affiliated with key organizations that have increased my interest in health disparities and health inequities. Howard University College of Medicine introduced me to public health and a community with limited resources as a first-year medical student. My subsequent participation in the Student National Medical Association, the J. Robert Gladden Orthopedic Society, the W. Montague Cobb NMA Health Institute, and an organization that I will refer to later entitled Movement is Life, have all sharpened my focus on service to the community, as well as to patients. Much of that work provides the basis of my remarks and my observations today. Next slide. Health disparities is a complex problem. The definition before you is the definition of Healthy People 2020, which defines health disparity as a particular type of health difference that is closely linked with social, economic, and or environmental disadvantage. Health disparities adversely affect groups of people who have systematically experienced greater obstacles to health based on their racial or ethnic group, religion, socioeconomic status, gender, age, mental health, cognitive, sensory or physical disability, sexual orientation or gender identity, geographic location, or other characteristics historically linked to discrimination or exclusion. This is interesting because the definition of health disparities has grown to be much more complex and really molds and melds into social determinants of health. 20 years ago, when I became involved with health disparities, and when the Cobb Institute was launched, we were most concerned about specific diseases or specific events, such as Hurricane Katrina in 2005, which pointed out the obstacles. Next slide, please. The initial recognition and coining of the term health disparities by the United States Congress was in 1986. And at the time of the Secretary's report, that was Secretary Margaret Heckler, whose report actually brought to the attention of the world what the National Medical Association had known to be true throughout its existence. And that is that there were many inequities when it came to health and to life and life expectancy and life quality with regard to African Americans, as well as other underrepresented minorities in the United States. So this is 1986. And the fact that African Americans had a shorter lifespan, and there were far too many what were called for the first time unnecessary deaths in the United States, each where it was raised to a new level of national awareness. This was about the time that I became involved on a national level with the National Medical Association. Next slide. So following the impact of the Heckler Report, the National Medical Association and other organizations were very focused on health inequities. The American Medical Association at that time was not focused on health inequities. We will talk about that part of the story later. There was then commissioned a study at the National Academies of Science, Engineering, and Medicine, and specifically the Institute of Medicine, to look at health disparities. The classic report, Unequal Treatment, was presented, which included a 10-year literature review prior to the time of 2002. The focused disease categories were cardiovascular disease, cancer, cerebrovascular disease, and others, HIV/AIDS for sure, asthma, diabetes, and even pain management. However, besides access to kidney transplant, very little was stated with regard to disparities relating children's health services. And there were no mentions of other health disparities and other conditions at that time. Next slide. The conclusions of this study were that the sources of the disparities are complex and are rooted in a historical and contemporary series of inequities and involve many participants at several levels, including health systems, their administrative and bureaucratic process, utilization managers, healthcare professionals, and patients. So this was the first time that it was clear that this was a system issue that was affecting all of our healthcare organizations, from our academic organizations to our government organizations as well. And there was the lingering inequity in healthcare that actually predated the Civil War, that still remained alive and well in the United States. Next. The National Medical Association, an organization representing African American physicians, and founded in 1895 because of the exclusion of African Americans in the organized medicine experiences in the United States by the AMA, was therefore founded in Atlanta in 1895. I served as the 99th president of the National Medical Association in 1996 and 1997. The association had members who were very involved in the unequal treatment document, which I previously discussed, and felt that it was necessary to establish an organization that would focus exclusively on health disparities. Therefore, it was launched at Howard University, my alma mater, in 2004, and it was named for Dr. W. Montague Cobb, who was also a past president of the National Medical Association and was my anatomy professor at Howard University when I was in medical school. He did many, many other things as well that I don't have time to discuss at this time, but health disparities was a main focus of his agenda throughout his professional career. The Cobb Institute now is a 501c3 organization that has been very active with various levels of the government, as well as many medical schools, as we continue to study health disparities. Next. The mission of the Cobb Institute is to focus on identifying and developing solutions, and I stress solutions, that will reduce racial and ethnic health disparities and improve the health of all underrepresented minority patients. Next slide, please. So, what are health disparities and healthcare disparities? Health disparities essentially mean that there's a higher burden of illness, injury, disability, or even death, which is experienced by one population group relative to another group. This is what unequal treatment identified and set about trying to find the reasons that this is the case. The more complicated definition of health disparities from Healthy People 2020 that I read previously is the work of 20 years of really trying to understand and eliminate health disparities. Sadly, that has not occurred. We still have health disparities, as we will further discuss. Now, healthcare disparities means that there's a difference between groups in terms of health coverage, access to care, quality to care, follow-up care, cost of care, that otherwise would ameliorate many of the differences between groups based on health disparities. So in a word that says, even though there are health disparities, and even though some individuals may have more likely, will be more likely to have diabetes or to have osteoarthritis, their care is even more impacted because of lack of access to care, quality of care, all the things that we should be able to correct for in the United States in 2022. Next. So disparities are linked to many different segments. Next. Age, sexual orientation, location, race, socioeconomic status, gender, and disability. We also know that there are certain conditions that have genetic differences among people, both geographic, demographic, and racial. However, those are not the major reasons why there are disparities. Those focus upon certain conditions such as blood disorders or some of the type of cancers, even some of the congenital conditions which occur. But as a rule, genetics is not a part of disparities. Genetics is a reality, but it is not the major reason why we have disparities. And that's extremely important because in the past century, it has been stated many times that genetics are the reasons for all of these issues and challenges in health. And that is absolutely not true. Next. The Movement is Life is an organization that has worked to, over the past decade, to focus upon musculoskeletal health disparities. And so I've been very involved in that because I'm an orthopedic surgeon. And we find that these health disparities are greatest among women, regardless of racial identity, regardless of ethnicity, that there are disparities in musculoskeletal health, specifically with osteoarthritis as it relates to women, as well as underrepresented minorities. And we have found that the specific focus is upon osteoarthritis, which is a condition that can cause severe pain, weight gain, immobility, loss of work, and loss of family support. And the condition is complicated by increasing age and decreasing morbidities. Further, it's complicated by comorbidities of health, specifically diabetes, obesity, and hypertension. So that the strategic objectives of Movement is Life, which is a consortium of organizations that's now a 501c3 organization as well, is to reduce disparities through the collective input of the patient, the provider, the community, and focusing on the policy level. Next. And this is sort of a summary of how Movement is Life addresses the vicious cycle. The vicious cycle is the cycle in the center around movement, showing that when there is greater joint pain, there's limited movement, therefore limited physical activity, therefore weight gain, therefore increased pressure on knee joints. And of course, this has been my life professionally for 48 years in trying to solve these pain challenges in the knee and in the hip joint in particular, our weight-bearing joints. And you see the comorbidities, heart disease, diabetes, and depression there in the center. But the green ring around it is the subject for today. Those are all the factors of social determinants of health. So therefore, regardless of what goes on in the center with regard to the patient and the provider, all of these factors lead to inequitable care. The zip code, the wealth gap, lower life expectancy, literacy, certainly stress, mental illness, structural racism, unconscious bias, employment. All of those affect health. And as a result, public and private policy must work to change these conditions in our communities, whether it's Manatee County, the state of Florida, or the United States. Next. So where are we now? Blacks and some other ethnic minorities have greater incidence of arthritis and chronic disability than the population in general, but at the same time have a lower use of total joint arthroplasty for a variety of reasons, again, related to patient trust, limited satisfaction with the results by peers, access, all of those causes. I have certainly worked to make a difference, and this summary is from a paper that I wrote along with Dr. James Slover, who is now at Columbia, on the ethnic and racial disparities in joint arthroplasty. And I just realized this was 11 years ago. And unfortunately, nothing has changed. Next. And so here's a snap in time from a study in Dartmouth in 2011, just so you can understand that because of the lack of access to joint replacement, the rates of hip replacement among Black Medicare beneficiaries or VA beneficiaries who we would think would have the same level of health care coverage, was 1.9 for 1,000 for Blacks, and for all other enrollees was 3.6 per 1,000. The same figures are shown for total knee replacement, so that there's about a 1-to-3 ratio. This is a very alarming statistic. Next. Next slide, yes. And the real concern and the reason why we must stay on this task until we eliminate disparities is that there's an economic burden of health inequalities and health disparities. It was defined by this Joint Center for Political Change study in 2009. This was around the time of the Affordable Care Act, and it was done to point out the economic burden and to point out how having more access to care, more appropriate treatment in the time would make a difference in terms of our total expenditure for health in the United States, as well as to try to decrease the lost time from work. Next. And this just indicated, even at that time, so this was now 13 years ago, so these costs are much higher. But there were direct medical costs, indirect costs of health inequities, and cause of premature death, meaning that, again, going back to 1986, we found that certain groups of people don't live as long as others, and therefore not in the workforce as long as others. And there's a cost to that. And we all share that cost. Please go back to the other slide. Between 2003 and 2006, the combined costs were $1.24 trillion. So we can estimate that that probably is at least double by today's standards. Next. So the social determinants of health, again, are those factors that are related to the conditions where we were born, where we grow, where we age, where we live, where we work. Our childhood experiences are important, as I mentioned before, living in the Brown Belt. I found that at 20 years after high school, I had many of my classmates who were ill or had passed away, possibly because of industrial situation in the steel mills of Gary, Indiana, and Northwest Indiana. But also all the other factors as well. Family income and wealth, extremely important. Education, extremely important. And we've spoken already about the access to health services and also the crowded housing. Next. And so, again, the World Health Organization defines social determinants of health with the same ring of, this was the green ring that we previously discussed with Movement is Life. Next.
Dr. Morgan, we have about 5 minutes left, just to let you
Okay. So let's just move through if we can. So we've already spoken in detail about the social determinants of health. I'd like to move on. The World Health Organization in 2008 did a study on the social determinants of health and started a program called Closing the Gap in a Generation. So we're in the midst of that first generation worldwide and have a ways to go. Next. Most importantly, and what we've been working on for the last year and a half, are the impacts of the social determinants of health because of COVID. So all of these factors that we discussed with regard to social determinants have become complicated by COVID-19. And we can come back to that. CDC director, you can move on to the next slide. The CDC director spoke of the fact that these disparities and inequities are in large part due to racism in the health system. And this is what will be addressed by our next speaker and discussed in the proclamation for Manatee County. Next. Other consequences include education, as we know, when students have disrupted their cycle and it affects their graduation rate, it affects their achievements. So there's a lot of downstream effect from the COVID-19 impact on the social determinants of education in our community. Next. And the National Academy of Medicine has focused on post-COVID-19 recovery plans. And this is what we in the Cobb Institute and the National Medical Association are most concerned of now, is in rebuilding our communities and making it possible for people to get back to where they were in terms of progress and health in the life course. Next. So the American Medical Association was founded in 1847. I mentioned that it excluded Negro physicians at that time. And next, many of the problems that we face with regard to health disparities are as a result of what we call the slave health deficit. And these are all impacts that come as a direct descendant of slavery and the Jim Crow America. Hypertension, cancer, diabetes, almost any condition, HIV/AIDS is more impacted in African Americans. Next. This was the apology to Tuskegee. And at that time, you see, I was president of the National Medical Association as I shook hands with President Clinton at this apology. This is one of the most moving episodes of my life. And as I stated then, Mr. Clinton's apology did not excuse the tragedy of the Tuskegee apology, but it may help close this unfortunate chapter in our nation's history. And what we have found is that it hasn't closed that chapter yet. We still have a great deal of distrust of the health system and the government, particularly among African Americans, because of the Tuskegee apology. And this was almost 25 years ago to the day. Next. So the American Medical Association now in its attempts to make right the inequalities of the past have come with their first strategic plan to embed racial justice and advance health equity. This is a major step from AMA, and though it's about 150 years late, at least it's a step. Next. So we know again that joint replacement disparities continue to exist, but disparities continue to exist at other levels as well, many other diseases besides joint replacement. Next. Racial equity is not just the absence of discrimination, but also the presence of values and systems that ensure fairness and justice. This will be the challenge for Manatee County and our entire nation in the next decade. Next. So this wonderful illustration explains what the solution for inequity means. So that equality, if we all are equal, everybody benefits from the same support, there's still a disparity there if you have boxes beneath each of those young men. So if there's equity, that means that everybody can now see because some have a larger box than the others. So this is affirmative action, which is in some cases not always popular in our nation. But finally, if all the barriers are removed, there is no further inequity, and therefore we have justice. Next. Thank you very much. And I look forward to the questions and answers at the end of the next speaker's presentation.
Dr. Morgan, thank you so very much for your profoundly informative presentation. I'm going to move on to introduce Teresa Kelly. Teresa Kelly is the Executive Director of the Health Council of West Central Florida and has over 35 years of experience in health systems planning and public health. She became interested in health disparities early in her career when she worked in the Miccosukee tribe. Miccosukee, I apologize, tribe of Indians, and later on for the United South and Eastern tribes. Indigenous people's life expectancies at the time were on average 15 years shorter than the general population, and they had the shortest life expectancy of all racial and ethnic groups. While that gap has closed to less than 5 years in 2021, that inequity lit a fire that has driven her throughout her career. The Health Council of West Central Florida believes that focusing on social determinants is critical to improving public health and works to bring together partners committed to system change and removal of barriers that prevent everyone, everywhere from obtaining optimal health. Teresa?
All righty. I am going to share my screen here and let's see. Okay, so we are going to talk a little bit more. I'm going to try to build off of what Dr. Morgan had said and kind of take this down to a bit more of the local focus for us right now. And we'll kind of start with that. So as Dr. Morgan had talked about briefly, is that really the things that impact health, the genes and biology generally is around 10%. Physical environment, another 10%. And clinical care accounts for about 10% of it. But when you look at individual health behaviors now, and that would be things like smoking, lack of exercise, nutrition, unsafe sex practices, a variety of things, those kinds of behaviors, lack of seatbelt use can account for another 30% of health outcomes. But the largest indicator really are those social and economic factors, and accounting for about 40% of an individual's health. I like to preface this part of it by the choices people make depend on the choices they have. And I think this is really important as we start talking about these things. I frequently hear that, well, why don't people just eat better? Why don't people get out and exercise more? Well, the reality is because of things in physical environment, social and economic issues, education, knowledge, all of those things impact the choices that people have. So I try to keep that front and center as we think about what's coming ahead. So for Manatee County, we're going to start first with the economic stability indicator for the social determinants of health. And poverty and income really are what we're going to talk about here. So the good news is in Manatee County, the median family income is actually higher than it is for the state of Florida at $59,000 versus say $55,600 for across the state of Florida. The household median income for whites is about $60,000 versus $58,000 for Florida. Manatee County also has fewer families by percentage in poverty at 7.6% versus 10%. And white families have even lower percentage of families in poverty when compared with Florida. The bad news is that when we look at median family income for Blacks, it's 33% lower than whites in Manatee County. And it's also 2% lower than the median income for Blacks in Florida as well. So, not only are Blacks doing worse than whites in Manatee County, they're also doing worse than Blacks in statewide average. Hispanic median income, family income is around 45,000 versus 49,000, 8% lower when within Manatee County than with the state of Florida. And then Black families in poverty are actually higher at 19.6% versus the 18.1% in Florida. So then we take kind of a look at some hourly wages, and this is a 5-year average and ending in 2018. We're looking for some more recent data, but there's still some issues on some of the 2020 census information. So data tends to lag by about 2 years. Hopefully there'll be some more recent, more current numbers available, but we'll go from there when we have that. But again, here I want to point out that, so when we think about the average hourly wages for Blacks was $14.60 versus Asians who in Manatee County who had the highest at $20.90, with whites non-Hispanic. And let me be very clear that there's, when we think about Hispanic, that includes all races that identify as Hispanic. So when you take out the white Hispanic, white Hispanics may be doing less well than white non-Hispanics. So you can see that those rates go all the way down. And it's indicative of a few things, which I think will become clear as we look at some other indicators with regard to that. When we think about, I forgot my poverty slide. So when we think about poverty, though, one of the things we need to be careful of is that poverty is really a very low threshold. It's a very low standard. There is also an element called ALICE, which is asset limited, income constrained, and employed. always have to think that through. But this is a measure that basically looks at the fact that, just because you make more money than you're not in poverty by the federal definition, which is about $12,400 for an individual, and then you would multiply that for a family of 4. The fact is about 33% of people still who are working, and that's where the asset limited and employed part of it comes in, are still not making enough money to meet their basic needs. And so I'm sorry I dropped that slide unintentionally, but just wanted to make sure that we think about that. So a lot of things are based on that poverty measure, but that poverty measure is a really low bar. When we think a little bit about social and community context, I want to talk a little bit about the juvenile justice system. So this is really kind of a bright spot in that the state DJJ has been working really focused and very intentionally on exploring what's happening with racial and ethnic differences in their contacts within the juvenile justice system. So really, if you look at Manatee County, we're looking at youth, which probably I think goes from the age of 12 to probably 17. So if we take all of those, 51% or almost 52% of people in that category and those age groups are white. And when we look at the number of arrests for youth in Manatee County, about 21% of them are white. When we look at the Hispanic youth, again, all races for that 31.9%, but they represent 35% of the arrests. So that's a fairly even balance. When we look at Black youth, however, almost 14% of the population is Black, but they account for 44% roughly of the arrests within Manatee County. So, that's really where this disparity, ideally, you would expect to see something fairly similar to what you're seeing in the Hispanic population. But when we get down here, it's that. There is a very interesting report that's referenced on that, which I think will give you a little bit more background if you want to go in to look at it. But the good news on that is that they're looking at that very specifically and trying to develop individual responses based on the district, the circuits that are involved with that. So there's some good news there, in that at least awareness is the first step. When we look also about disconnected youth, and this is the individuals 16 to 24 years old who are either not enrolled in school without a high school diploma, so or not working. So again, as we kind of look at this, the percentages where Hispanics across all races, actually that one looks much higher than when we're talking about just specifically Blacks or non-Hispanic whites. But when you factor across all races and ethnicities, you have about 10% of the youth are really just not engaged. And so that points to a lot of issues, such as, you know, high school graduation rates and the ability to go on for higher education, to get jobs that will strengthen your ability to financially to survive, as well as your literacy levels to be able to understand health information and to make informed decisions about your care and choices that you might be able to make once you know about what those choices are. And when we look at education specifically, this is bringing just a 1-year school year, so the most recent school year period that we had prior to COVID hitting. So COVID has, as Dr. Morgan has indicated, changed the game on a lot of these indicators. And so we're kind of taking that point right before COVID, or just in a little bit after it had hit. And again, the blue line is how Manatee County is faring versus the gray line, which is the state of Florida. So again, you can see that doing slightly less than the state averages for some groups, and looking at different males and females makes these comparisons very interesting to try to get a sense. Females tend to be doing better, coming in closer, whether they're Hispanic or whether they're just females across the board. So we see that some of these are the graduation rates, and we know that that's really critical. The other good news on that, however, is Manatee County Schools through, and also the Youth Development Committee on the Manatee Alliance, which we'll talk about in a few minutes, are really focusing on that as well. So there is real awareness, and they are really looking at solutions and using best practices of things that are emerging around the country, as well as figuring out what will work best in Manatee County. So again, a little bright light coming down there, and that action is occurring on that. When we look at populations with a bachelor's degree or higher, again, within Manatee County, about 50% roughly of the Asian population, which is a fairly small population relative to the overall population, but among them have the highest rates of bachelor's degrees or higher. And then again, not surprising, Blacks have the lowest percentage of that when we think about Manatee County versus all races hitting near 30%. Blacks are still have about half of that. So again, it's kind of paints that picture as to how we are one of the reasons why I'm sorry, I'm having a hard time today. One of the reasons why our disparity rates are worse in health outcomes. Same thing when we look at neighborhood and built environment. So home ownership rates are really one of the indicators where we look at how stable communities are. And again, for a host of reasons, whether we look back to redlining and access to capital and access to mortgages and jobs that can support mortgages and all of those things that kind of fall together to create this whole systemic support for racism. That's where Blacks are, again, about 40% of the homeowners are Black, or within the Black community, about 40% are homeowners. But when we look across the non-Hispanic whites, we're getting up to 77%. So also, I'm trying to speed up here because I know we're short on time, but transportation. It's estimated that 4.9% of the households in Manatee County have no vehicle available. And the American Community Survey estimated that about 79% of those employed residents drive to work alone. When we look at population that are actually walking or using public transit to work, it's relatively small across the board. But again, here we will see, as you would expect, that Blacks have the highest rate of people who are either walking or taking transportation to work, public transportation to work. Healthcare, on the healthcare access component for social determinants, we have, so income, again, thinking about income and insurance generally tied together. We also know that Medicaid is not particularly generous within the state of Florida, particularly for single adults. It's almost impossible to get Medicaid. So that safety net doesn't really exist in a comprehensive way. But the interesting thing I think that I want to draw to your attention here is that it's whether you have insurance or not is not necessarily a function completely of your income level. So those with 138% or less of federal poverty level, about 24.2% in Manatee County, would be uninsured. When we get to the 200% of level of federal poverty, then we're starting to see an uptick in being insured. But still, when we go up to over 400% of federal poverty, is still 27% uninsured. So it's a tough needle to move, but I think we also look at what types of industries we have in the community, and any of the tourism-based and retail-based, those types of jobs tend to not offer insurance. So you may be making some money, making too much to qualify for certain services, or having too much in assets to qualify for certain services, but still unable to afford insurance. And then, as most of you know, Manatee County does have an indigent healthcare program, which is available to low-income individuals, and those are below 200% of the federal poverty level, and only for adults for 18 to 64 years old. So about 5.1% of the population in those age ranges are eligible for services under the program. But if you look under the blue or the purple color is actually the number that are actually covered at this point. So for fiscal year 2020, that was not a complete year. So let me go back to 2019. We had 1,305 people actually covered. The red is the number of people that applied. The green was the number of people that were approved. And the purple was the number that were actually receiving services under it. So we have a whole group of folks that are eligible, that are not applying, and that are for some reason not being approved. And that can be, paperwork issues, needing to get all kinds of things. But the program is there, and it's wonderful for the people who are there. But in reality, there are a lot more people that would benefit from being able to take advantage of that program. Then we'd also have to look at what would happen if all of those folks did come into the system and what that might cost. So there are those issues as well. So I'm going to circle back just a little bit to what Dr. Morgan was talking about on the fundamental drivers behind health equity. And this is where we're kind of talking about structural discrimination, income inequities, the disparities in opportunity, disparities in political power. I mean, this is really it as we look at assaults on voter rights and things that are happening in the state, in the nation, to disenfranchise people from their political power. This is something that is going to make this situation worse. And governance that limits meaningful participation. So I think most of us have been to a public hearing, have been to something you get your 3 minutes to get up and stand, but are we actually getting individuals who can tell us what's going on involved in the very beginning when we're designing programs, when we're looking at the policies as to how we are going to implement things? Are we talking to the people who are supposedly the ones we're going to serve? Are they actually involved in that in a meaningful way before it even gets off the ground? So the Robert Wood Johnson quote that I like for addressing health equity, it is about requires the removing of obstacles to health, such as poverty, discrimination, and their consequences, including powerlessness, the lack of access to good jobs with fair pay, quality education, housing, safe environments, and healthcare. Inequities in one system connects to inequities in the other systems. I know we all hear a lot about diversity, inclusion, and equity, and I just kind of want to, I love this slide because it kind of helps to help you understand what the difference of those things are. So when we talk about inclusion, it's really needs to involve authentic and empowered participation and a true sense of belonging. It's not just simply that you're there, it's that you have a true sense of belonging and inclusion with the group. When we talk about diversity, that's about the variety of the personal experiences, values, and worldviews. It's not just about race, ethnicity, and gender, though, although those are the things that we tend to look at when we think about diversity. But sometimes we need to take that concept of diversity to a little bit deeper level, in that not everybody who is white is going to have the same experience. Not everyone who is Black or Indigenous person is going to have the same experience. So it's about really getting down to a little bit deeper level on what that diversity looks like. And then when we talk about justice, so as Dr. Morgan was referring to, this is kind of the combination, the comparison of what it is. So diversity asks who's in the room. Equity responds who's trying to get in the room but can't, whose presence in the room is under constant threat of erasure. And then inclusion says, has everyone's idea been heard? But then we think about that for justice. The justice response on that is whose ideas won't be taken as seriously because they aren't in the majority. So again, we kind of need to think about the act of creating these environments where people really feel welcomed, respected, supported, and valued, by eliminating those practices and behaviors that are marginalizing people. So we put in the chat the link to the Manatee County proclamation, which Manatee County, I believe, was the first county in the state to pass a proclamation of racism as a public health crisis. And I do think that there was hats off to, I think Josh Barnett was critical in getting that happening. We have had a few other cities and counties throughout the state adopt some of these, and this is a major focus for the American Public Health Association as well. And I just kind of want to highlight a couple of things. Several of the action steps that were laid out, there were 11 points for action. A good number of them actually fall with the county commission itself in dealing with their county staff and their administration. And how do we as individuals, as agencies and organizations interact with this proclamation as well? So the Manatee Health Alliance for Community Health is an organization of many organizations. It's tied back to our community health improvement plans, which are coordinated by the Manatee County Health Department. And these are done every 3 to 5 years when we start looking at where we can make the most impact. And as I was talking about in the education portion back there, with the Manatee County Schools, there is a youth development committee, and the schools are a big part of that focus. They are doing some amazing work on trying to look at a number of things with regard to that. So this gathering has a series of work groups that focus on different items. When this proclamation was passed, we did present to the Alliance, and in full disclosure, I am a member of the board for the Alliance as well, which I really enjoy doing, and I have been continuing to go to these meetings for probably over 10 years. But I think it's probably at one of its most active and vital stages right now that I've ever seen. We tried to look at what kinds of things could members of the Alliance or the Alliance as a whole start looking at. And so picked out really these three. Was the number 6, which was support community efforts to amplify issues of racism and engage actively and authentically with communities of color wherever they live. You know, we've had a lot of engagement over the years, but I think as we look at those words actively and authentically, it's really, that's the heart of it. And we really need to continually grow and develop. It's not something you ever are done with, it is just a constant value that needs to be kept in the forefront. Number 7 was to always promote and support policies that prioritize the health of all people, especially people of color, by mitigating exposure to adverse childhood experiences. So the ACEs tend to focus on a lot of the mental health and trauma related things that go on, but those things can also be tied back to the environment, such as Dr. Morgan was describing. Those adverse childhood experiences can have long-lasting impacts into adulthood and can affect physical health as well as mental health and substance use, and those behaviors that we talked about as being roughly 30% of your health outcomes. And then in number 9 was encourage racial equity training among all community partners, grantees, vendors, and contractors. Now, I know we've heard a tremendous amount of concern around the concept of critical race theory and what that might mean. And the environment that we're working in now is that there is definitely pushback. As the league looks at this from an advocacy standpoint, these are things that I think could be things that we want to focus on as encouraging and trying to make people aware that, you know, the term critical race theory gets people's backs up. It's probably not a good term because it's, you know, was an academic term and it's being taken out of context. But the context, the content of all of that is what really is important. And how do we mobilize that within our community in an environment where there is a lot of pushback? So that's one of those things from the advocacy standpoint to try to figure out for the league's purposes, what you might want to look at with that. I can say, yes.
We're gonna need to kind of wrap it up.
Okay, quickly. All right, so there's my contact. I do want to say that Hillsborough County does have a very active group that's working. Now, their proclamation was actually started by a church. They were the ones who actually went to the county commission and started, you know, demanding that they do something, and they are holding them accountable for everything that has come out in their proclamation. So it is about really getting grassroots and getting some individuals involved, as well as the agencies and organizations that would like to assist you with. So I will wrap that up quickly. I'm sorry for the time.
Very good presentations. If everybody will stick just for a little bit longer, I did ask Ruth if she could just pick 2 questions to ask, so we do get the questions from our attendees. Ruth?
Yes. Phenomenal speakers and presentations. Thank you so much. One question that came in from Barbara, well, I might butcher her last name, but she was wondering if, from a policy standpoint, if pursuing single payer, where every person in the United States has access, at least financially, to healthcare versus through what is primarily insurance or indigent care. Would either of you have any thoughts whether that might be a significant step to addressing some of the inequality?
Dr. Morgan, I'll let you go first. I do have some thoughts too.
Okay, thank you. Well, thank you for the question. The National Medical Association has been an advocate of single payer health systems since about 1946. So that this is something that throughout my lifetime of professional career has always been on the agenda of the organization. That being said, translated means everyone should have the opportunity to have quality health care. And the payer, the process is to be determined. And certainly any type of process that we have heard discussed in the various political campaigns has not been universally accepted, but I do think we have to accept the reality that we have to do a better job of providing health care and not overstepping our resources as a nation.
And I would agree
Teresa?
with, yes, I would agree with that. I'd say it's more about universal access than a particular payment method necessarily. There are hybrid models that might work with that. But I would say it also, as we think that, you know, if healthcare is roughly in that, was in one of those 10% figures, it's what's happening when they're in healthcare, when they're in their physician's office or when they're being seen, that is really where the rubber's going to meet the road. And that's, you know, we see with accountable care organizations and people that are utilizing community health workers that are assessing the patients that are coming in and seeing what are your other needs. Do you have food? Do you have a safe place to live? You know, what else is going on? Do you have refrigeration to keep your insulin cold? All of those things that needs to be embedded into this as well. It's not just about making sure that somebody can get paid to see you. It is about whether or not, you know, what that care is going to look like when you're in that door.
And the second question really came in from, or was Angela was wanting to point out when and the educational system seems to be very much a part of where these disparities and inequities come from. And then how can we, are any thoughts about addressing things within the educational system? The League of Women Voters of Manatee County certainly has taken a position with the Manatee School Board regarding diversity, equity, and inclusion. But Teresa, thoughts about the educational system playing a part in all of this disparity?
Oh, it absolutely plays a part. But again, remember, all of these systems really impact each other. So if we are not investing in schools, if we are not, we have some schools that perform much better than others. So why is that? It doesn't all boil down to neighborhood. We need to be looking at education from really that 0 to 5. I mean, that is where so much happens, and we do not value that early childhood education. We don't fund developmentally appropriate childcare to the extent that people need that. That, you know, there are, when we look at the education system, that is all part of it, but it's also impacted by those things, that what happens when the child goes home. You know, what are they dealing with? Are they getting enough nutrition to be able to focus? Are they, you know, yes, we have school lunch and all of that stuff, but what happens on the weekend? What happens when they can't have enough, or there's enough for the children, but maybe mom and dad don't get enough? You know, I say this, that the awareness, I believe, is there. But the problem in isolating one of these is that we have to understand how the other types of social determinants play into it as well. I mean, you can try to tweak what you can within one system, but you still have to look at a whole systems approach and how all of those systems integrate and help or deter the progress.
And I am going to appreciate everyone staying on a few extra minutes, especially our speakers. But I have one last question. I'll address it to Dr. Morgan first and then Teresa. What one action could we as listeners, people that have listened to what you have presented, what's the one thing that you would encourage us listeners to do as an action after we leave today's meeting? Dr. Morgan?
Well, thank you. Thank you for the question. And hopefully my presentation and that of Ms. Kelly as well have stimulated the desire to learn more, because the one thing that can be done is to learn more. We're we're not experts at this, even though we've been working at this. There's still so much to know and so much to understand that I think it's really important to not even think that we have a great enough understanding to correct the health inequities that that presently exist in our nation. And so we're all just take a step back and try to prepare ourselves through learning, through talking, through interaction, reading. I think really that'll make a difference. And I know it sounds simplistic, but sometimes whenever there's a problem, we're all jumping in to come up with a solution when we're not prepared to make a solution or to contribute a solution. But I do think that education is important. And just as a tie into the previous question, the impact on the education system is also affecting our providers. And so the fewer providers that we have in our communities and healthcare, the more difficulty that we're going to have in maintaining equitable healthcare at a high quality. So we've got to rescue that system, get people trained as nurses and physicians and all other, as those who are working in the health system. And so our education system is crucial to making that occur.
Thank you. Ms. Kelly?
Well, I'm going to put in a plug for the Manatee Alliance. There are a few committees, and I know Dr. Bensie's on this, so she can correct me. I know one of them deals with wellness and things like physical activity, nutrition, and all that. There's, I believe, mental health. We have one going on with that, and the Youth Development Committee. They're really looking at some measurable things that we can be doing. These give you an opportunity to see how some of these concerns are, where we're really at and what kinds of approaches are working. And as I said, the Alliance did agree that it would be helpful to have some type of social determinants, a look at health disparities. And frankly, I was the one who was supposed to pull that together. And I got rather busy with other things. And so I will make the vow now to come back around and try to see what we can have, just to have some conversations about what might be possible. What can we do to educate the community as a whole, versus as well as educating ourselves. And it is a constant thing. You're never done with this. There's always new stuff to learn and new things that are happening, that are being tried, that are transferable to other areas. And so there's a lot of work to do. I would say pick what interests you, that's going to hold your attention, and stick with it for a bit.
Thank you to our excellent speakers today. We're very happy to hear, Teresa, that we'll be moving forward. And please visit our website, lwvmanatee.org. And on the front page, you can sign up for our newsletter. And again, thank you very much for